planned strike, and we can't expect a lot of people coming to WHO because they're allowed to work from home. Anyway, so dear colleagues and friends, welcome to the 84th Global Health Histories Seminar. The subject of today's seminar is civil registration, the anchor for universal health coverage. The Global Health History Seminars series was established in late 2004 and is hosted jointly by WHO and WHO Collaborating Center for Global Health Histories at the University of York. Seminars take place once every month and are broadcast via the internet. I'm honored to introduce my co-chair, Professor Sanjoy Bhattacharya, Director of WHO Collaborating Center at the University of York, and our two speakers, Professor Simon Szreter, from the University of Cambridge, and Dr. Colin, coordinator of the Mortality and the Burden of Disease in the Health Statistics and Information Systems Department of the World Health Organization. Each of the two presentations will last for about 25 minutes, followed by the Q&A session for both speakers, which will be chaired by Professor Bhattacharya. Kindly remind everyone to speak into the microphone and give your names, since the seminar will be broadcast. The first speaker is Professor Simon Szreter. Dr. Szreter is Professor of History and Public Policy in the History Faculty, University of Cambridge, and a Fellow of St. John's College, Cambridge. He is a founding member of the History and Policy Network and a chief editor of its electronic journal. His main fields of teaching and research are demographic, social and economic history, and the relationship between history, development, and contemporary public policy. In 2009, he was awarded the Versailles Prize by the American Public Health Association for outstanding contribution to the history of public health. Professor Szreter, please.
Thank you very much, Jing, and thank you, Sanjoy, for inviting me over. It's a great pleasure to be here talking today on this topic of civil registration as the anchor for universal health coverage and giving a historical perspective on this. Good, okay. The talk is really in three parts. First of all, talking about the historical case in Britain, and then reflecting on what we can learn from it historically. The first thing about the British historical case is how long-running it is. I think we tend to think of identity registration systems and universal health protection systems as quintessentially products of the modern world, welfare states created in the mid-20th century. Identity registrations, people know that some of them were created in the 19th century, but they're modern pieces of state equipment. So one of the first surprises that an investigation of history gives us is to discover that in the country where industrialization happened first, the first country, if you like, to modernize, in England in particular, there was a universal healthcare system created and an identity registration system by the Tudor monarchs, Henry VIII and Elizabeth I. Of course, these were Henry VIII took England into a Protestant Reformation, became a Protestant Reformation society, as a result of which I think the interest in preserving social order and protecting the population against dearth and famine became a higher priority, since the crown was now really where the buck stopped. Previously, religious orders had provided some succor to the population in hard times. Having a bit of trouble advancing this. Oh, there we are. So the Elizabethan Old Poor Law statutes of 1598 and 1601 are reckoned to be the founding pieces of legislation after about 5 or 6 decades of experimentation, in fact. And the crucial things that they establish are a universal legal right to relief for all subjects. In practice, this is devolved to 10,000 parishes, approximate population at that time about 500 inhabitants of each parish. It's financed, interestingly, by a progressive local tax pro rata on property values in each parish, and it's specifically to support the local poor all the year round if necessary. This is not just about crisis, times of dearth and famine. It is for the elderly, the widows, the orphans, the ill and the unemployed whenever they whenever they are in need. So it's a genuinely universal system, but highly devolved to the parish level, and it's mandatory. The Crown is very keen to ensure that every parish establishes this institution. So the Poor Law, as it was called, which exists in this form for two whole centuries before England industrializes, consists really of 4 interlocking institutions of local government mandated by central government, providing this effective and accessible welfare state at the level of the parish. So there are the poor laws themselves, the founding statutes. The justices of the peace, the local magistrates, are very important. They oversee the system. They ensure that each parish is indeed establishing a fund. People are paying into it in the right way. They can be punished if they don't. It's also providing cheap and accessible justice for people who feel they have a grievance. If somebody thinks that the overseers have refused them but they are entitled to pay, they can go to the justice who lives locally, resides locally, but holds his office at the pleasure of the Crown, so he's not in the hands of the local landowners and the wealthy. And this is famously a phrase that was used at the time, that the poor can approach the justice of the peace in the public house or on the hunting field, wherever he may find him. So the idea is that justice is accessible and immediate. So this is an important part of this system for its credibility. The settlement laws, which come into, which are in their final form are settled in the 1660s after about 40 or 50 years of further experimentation, are the laws which establish the rules of entitlement. Every subject has an absolute right to relief, and the question is which parish. They have that right to relief in one and only one parish, and the settlement laws define what they are. And the default, of course, is the parish that you are born into. But for women, for instance, an important point is that your parish of settlement, the place where you have a right to claim your entitlement to relief, moves to the parish of your husband on marriage. So this means that for this system to operate with a mobile population, and unlike many sort of stereotypes that we may have, actually English early modern society in the 17th and 18th century was quite mobile. It wasn't the case that people simply lived and grew up, lived in the place they were born. There was quite a lot of mobility. So given that, the parish registers then become really quite important, because they're what records where you were born or where you married. So for the poor, this becomes really quite an important document that you want to register into, and you want your children to be registered for. The parish registers were in fact instigated even before the Poor Laws. They come in 1538, quite soon after England's Protestant Reformation. Of course, this town is very famous for its own Protestant Reformation at almost exactly the same time. Calvin was very active in the 1540s here in Geneva. 1538, brought in by Thomas Cromwell, the absolute classic kind of meritocrat, son of a blacksmith, who became Henry VIII's most trusted minister for almost a decade. The purpose of the registers when they were originally created was very interesting. They were both to provide a relatively transaction-free legal record of title to property for inheritance purposes, as this direct quotation from Thomas Cromwell attests. And they were also a system for trying to ensure that as much of the population as they could get would sign up to become members of the Anglican Church. Of course, this is a time in the 1530s where there's still a question about whether the population is going to follow the monarchy into its Protestant Anglican Church, or whether the people are going to stay as recusants and try to retain their Catholic faith. Well, the establishment of this system of registration is quite a strong kind of inducement to place yourself into the Anglican Church and accept its rites of baptism and marriage and burial, which will give you the record for your family for good. This system endures for 300 years. We know it endures because it's those records that enabled the Cambridge Group for the History of Population to produce their extraordinary research in the 1980s on the population history of England. They took a 4% sample, 404 of the 10,000 parish registers, in order to give us the knowledge that we now have of English population change over time. We also know the system was there because of all the litigation that was generated with parishes disputing with each other about who was really responsible for any particular indigent individual, and that's generated a lot of very handy research, documentation for us as historians, which again confirms that this system really did exist. It wasn't simply a couple of statutes signed by Elizabeth in London. It was actually a system that really came into existence. Furthermore, we have evidence of the levels of outlay. As you can see, at various points in time, various inquiries were made which tell us how much money was being spent on the poor law, this enormous transfer system, transferring wealth from the wealthy to support the poor. 1690s, 1% of national income. By the 1780s, 2% of national income is being transferred in this way. These are really colossal amounts of money for a society at this time. To set up a system of this kind and have it working in this way. By the early 19th century, in the worst years, we can see that 11% of the total population was in receipt of payments under this system. Because of particularly high prices at that time. So we've got a lot of evidence about the extent of the system. And finally, we have some really compelling demographic evidence. The Cambridge Group, with their analysis of parish registers, were able to look at the correlation between prices of food over time and the mortality rate of the population. And they find that uniquely in Europe, after the 1620s, there is no further correlation between these two, unlike the whole of the rest of Western Europe. When prices go high, when there's climatic problems and dearth, you see a mortality response in the population. In England, you don't see that anymore after the 1620s. So this system of poor relief is actually giving the British population fundamental food security 150 years earlier than is achieved anywhere else in Western Europe. So that's a description, a quick description of some of the outlines of this system, how it interrelated between the interrelationship between the security system and the identity registration system, and now looking at various possible lessons for contemporary policy about this history. I think one of them is about getting the incentives right. In relation to the property owning class, who were predominantly the contributors to this system, it's very important. Abraham de Swan noticed this 25 years ago in his book In Care of the State, that this system replaced a previous voluntary system of sort of noblesse oblige and Christian charity. The idea in many parishes did have a fund for the poor, which the wealthy tended to pay into, but it was voluntary. The big difference here is that the poor laws make this an obligatory system, so it doesn't depend any longer on the caprice or on the relative generosity of certain individuals. It's a system that everybody is supposed to pay into, and there's a machinery to oversee that, to try and ensure that people aren't cheating or trying to avoid their obligations. Secondly, the settlement laws became very important for policing, partly with reference to the parish register, the big problem of unlimited liability, because you can imagine that with 10,000 different parishes, the wealthy paying in any one parish would be particularly concerned that they might become liable for the poor of other parishes around them. So the settlement laws are the response to this, to set up a really clear set of rules about who is responsible, who pays for whom. There is litigation in the courts for cases at the margins, but this is an important part of the system. Any system like this has to both satisfy, both has to ensure that those paying in really are paying in, but it also has to satisfy their very realistic and reasonable concerns that they don't just have to pay for everybody under this system, that there are clear and transparent rules to police the system. Secondly, there's something very, very interesting about Elizabeth I's act right at the end of her reign. One of the things that's often charged against systems of compulsory universal social security like this is that they crowd out voluntary and philanthropic activity. The argument is that if you create a system in which the state, through mandatory taxation, provides for everybody, then the wealthy in society and those with resources simply stop giving. They stop trying to give. They stop trying to assist the poor. Elizabeth I and her ministers do something extraordinarily interesting, because in 1601 they also create the founding charitable statute, the 1601 charity law. And the intriguing thing about the 1601 statute, when you look at it, is that it says that charitable activity is almost exactly the same set of things that the poor law covers. Help for the poor, for the ill, for the elderly. The only thing that's different is that charitable education is covered in charitable activity, which doesn't fall under the remit of the poor law. So what is interesting about this is that the state, through these two laws, both in 1601, has set up a system in which it is basically saying to the wealthy in every parish, you are going to have to pay for the poor and the needy in your parish. This is mandatory. However, you can, if you choose, engage in intelligent charitable activity, which will no doubt bring kudos and high status to your families as being very generous people in your community. And by the way, given this mandatory system we've set up, if you get your charity right, you will also reduce the cost to you of supporting the poor. If you do set up schools to educate orphans, it's likely that they're going to be off your hands rather quicker than otherwise. So there's a very interesting set of incentives being set up here by this double system. And indeed, the evidence is that the wealthy and the elites in parishes do indeed respond. And if you go into parish churches in England, you will see monuments in the churches on their walls about what the great and the good did for this local community, how they established almshouses, how they gave money to the poor, and so on, when all of that is on top of the mandatory things that they had to do, pay in every year to the poor law. So we do see that they establish schools for poor scholars. They establish almshouses for the elderly so that they can care for the elderly in a more efficient way. Subscription hospitals start to be founded in the 18th century in British towns and cities as a solution to the problems, the big problems of health that create enormous poor law expenditure if you can't deal with them. And other creative local initiatives, apprenticeships for orphans I've already mentioned, and so on. So there's a range of activity that's being generated in Britain by this combination of a mandatory social security system alongside an inducement to engage in charitable activity. What about getting the incentives right for the poor as well? The poor law creates an invaluable entitlement to collectively provided relief, and the settlement rules say it's got to be in one parish only. This means that there's widespread voluntary buy-in by the poor to the parish registration system. Interestingly, the parish registration system of England has no compulsory fines attaching to it. It wasn't part of the original design. I think there's some interesting reasons for that. But still, we find that there's plenty of parish registers are so complete that historians today have been able to use them. The poor have this strong incentive to register because it's linked to their capacity to access the social security system in an effective way. And the marriage registers are also part of this. So what about general lessons for contemporary policy from this English history? I think one general lesson is that is registration and health protection systems live and die together, then they're actually not necessarily alternatives. They need to be thought of in practical terms as things that should be brought in together. They each support each other, or if you try and do one on its own, it probably won't work. A registration system with no particular incentives for the poor to sign up is going to end up being one that the state has to try to enforce, which is, I think, never a good idea for the state to enforce anything on the poor. On the other hand, creating and funding a health system with no kind of registration is likely to get into trouble because those paying in will get worried about unlimited liability, and there's no way of actually of knowing who's entitled to such a system. These systems worked extremely well together in Britain during the 17th and the 18th century, but interestingly, between 1780 and 1840, when the population goes through this very hectic period of intense industrialization, migration into big cities like Manchester and Liverpool and Leeds and so on, these systems do come under such pressure that they are falling apart. The registration systems, and it's very hard to use them to study the populations of these towns in these periods because the local incumbents who are supposed to be registering the births, deaths and marriages just get overwhelmed by the numbers coming in. The poor laws are breaking down because they can't cope with the weight of all the people flooding into their parishes. There are real problems. All of this ultimately leads to a radical revision of this system, the new Poor Law of 1834, and a revised registration system. The state finds that there are, by the 1830s, it recognizes there are so many nonconformists, Methodism, baptism, and so on has all grown in numbers so much that we now need a civil registration system, which is what is created in 1837. It's no longer good enough to think that everybody is going to participate in these Anglican parish registers. So the two systems have to get revised together. So we see that these two things still work, they're still functioning together. They get into trouble together, and they have to be reformed together in order to enable a system to carry on working in the 19th century. Of course, the 19th century poor law was a really rather different animal from the one I've described to you. It's the poor law that was deliberately created as a deterrent system. The famous Dickensian workhouses were built. The attempt was made to actually discourage the population as much as possible from using this system. So it's a very different animal, and I think partly the very widespread memory of that system is what's led to a kind of historical amnesis about the previous system that existed for much longer, for nearly a quarter of a millennium, well, the Elizabethan poor law system, which was a very, very different one. And I think its important history has been wiped from our memory as a result of the workhouses of Dickens's novels. When that system was created, the new registration system, Colin will like this one. This is a very early, this is William Farr, his first attempt to propagandize, to use the deaths registered in the nation to try to get the nation to understand just how bad the health of some of these big cities where these systems of registration and poor law had broken down. And this is a survival diagram for London, for rural Surrey at the top, for Liverpool in the middle, and for London at the bottom. And Liverpool was one of those fast-growing towns. On the left-hand side, you see the proportions, a column representing those aged 0, then age 5, 10, 15, and 20. And the black represents the proportion dead, as discovered in the death registers of the 1840s, matched up with the 1841 census. And you can see in Liverpool what this is showing, shocking finding, that almost exactly a half of those born did not live to see their 5th birthday in the city of Liverpool, whereas just 100 miles away in rural Surrey, 80% of those born were living to see their 5th birthday. So some further kind of lessons about for contemporary policy is that I think that civil registration systems should be voluntary, and they'll work best when all sections of the population, notably including the poor, have clear incentives to participate. Property holders always have a legal incentive. Property holders, people who think they're going to pass money on to their children and their grandchildren, will want to join such a registration system. It's the poor that you have to provide incentives for. They can't see the point of this bureaucracy, and some form of something like a universal health security system, or for instance, the Brazil with the Bolsa, some tangible valued services that the poor needs to be, I think, tied up with the registration system to get their voluntary buy-in. I think fining them and forcing it from the state is not a great way of doing things. It's a form of violence, which I think is not a good relationship to have between the state and the poor citizenry. The state needs instead to think creatively about providing the poor with something they value in order to induce their participation in this system. And linking registration to health is such an example. I think that given that the costs of any kind of universal health protection system must always involve transfers from the wealthier to the poorer, an efficient registration system is also important because it gets buy-in from the wealthy as well if they feel that this system is being policed properly, and so on. Lesson of British history is that such integrated systems of healthcare and registration are not necessarily, you don't have to wait until you become rich and developed like the mid-20th century European societies to create this system. Elizabethan England, Henrician England was incredibly poor by contemporary standards, and its literacy rates were fantastically low, but it managed to create a system where it was devoting 1 to 2% of its national income to this purpose. So it's not something that you have to wait until you're wealthy and developed. And in fact, English history indicates that these twinned institutions of universal health protection and identity registration may be an important part of the contribution to society, which enabled this part of the world, Britain and England in particular, to become the place where economic development and growth happened first, with a society that had this kind of protection, freedom from food insecurity, capacity to be mobile around their society without worrying that you were going to starve, because eventually you would always be supported, and particularly mobility in terms of the younger generation, because one of the crucial things about the Poor Law is it's providing collective support for the older generation in their own parish. So the older generation don't need to desperately hang on to the young to keep them beside them to support them in old age. This system releases the younger generation to become more mobile. And finally, registration and health protection systems can fall into disrepair, especially as happened in the late 18th and early 19th century. The new dogma of free markets, of classical political economy, of Smith and Malthus, said that these systems like the Poor Law didn't make sense. They were holding up, artificially inflating the price of labor, that everybody should look after their own interests. We shouldn't have collective systems like this. The market economy functions better if everybody simply pursues their own self-interest. So these systems can also break down. They can fall apart if they don't have the right political and ideological support. And if we think about the last 20 or 30 years, 40 years since 1945, it's clear that identity registration has had a low priority in terms of post-war development policies. It doesn't even feature, strangely, in the 1948 Universal Declaration of Human Rights. I don't know how they thought these universal rights were ever going to be attached to anybody, because they didn't know where these people were and they hadn't got any recognition of their identity. It doesn't really come in full force until 1989, when everybody signs up to the rights of the child, Article 7, with the exception, interestingly, of Somalia and the United States of America, which I believe is still the case today. So in practice, birth registration, and I know Colin's going to talk much more about death registration, but birth registration in around 2000 was very deficient in much of sub-Saharan Africa, in India, less so, of course, in China, where the hukou system, which was a compulsory system, was registering the population at this time. As a result of much enhanced appreciation of the importance of all forms of universal registration, birth, death, and marriage registration, A number of INGOs have been pushing this now in the 21st century. UNICEF probably was the leader here. WHO, Plan International, of course, India has very recently and very high profile gone into pushing for a universal registration system. And there's places like the Civil Registration Centre for Development in The Hague in the Netherlands. So there's clearly a lot more activity now in the last 10 or 15 years. However, 10 years after that map I've just shown you, although the colours are a bit different, there's still really quite a lot of problems in the same parts of the world where the problems were there before. And you can see perhaps the big difference, one of the big differences here is South Africa is now green, is in the top category, whereas previously it was in that dark blue category. India is moving up out of the dark blue. China, very worryingly, has gone into grey, which means there is no data that they are prepared to back. So I think that, you know, 2 or 3 things, if we use those examples, we've seen spectacular increase in South Africa, which is an extraordinary case because this is the land of apartheid, of the hated passbooks. But South Africa has got its citizenry to actually endorse registration by providing them with something very valued. Francie Lund's child support grant, which is attached to registration, I think is very important in producing that result in South Africa. India has this top-down system. We're not sure. You know, there are mixed reports about the success of this system. It's certainly the state is putting a lot of activity in. I suspect that it won't necessarily work that well unless they attach something that the poor want to it, as they have done in South Africa and, of course, in parts of Latin America. And China, this is just to draw your attention to the first chapter in this book, chapter by Richard von Glan, which I think provides a fantastic synoptic view of the Chinese hukou registration system across its full history, a book that was published in 2012, Registration and Recognition, looking at a world comparative history of this subject of identity registration. China, I think, is worryingly reminiscent now of England around 1830s and 40s. Looks to me like there's a lot of the same kind of forces of hectic urbanization through mass immigration, new ideology of allowing the free market to have full reign, of not worrying so much about collective provision of resources. It looks to me like the hukou system is probably falling apart in China. It was already getting into trouble in the 80s because they didn't want to register the so-called black population of second and third children. We know there's a big floating population in places like Shanghai and all the biggest cities of people. And, you know, one wonders whether when they finally get, if the Chinese finally get their registration system organized again, whether they're going to discover what William Farr discovered in places like Liverpool when they do so, that they get that what they've actually got is a population of enormous health disparity, with perhaps some really shocking figures in the biggest cities. So I think I'd better. Have I got a minute or two, or should I stop now? Yeah. Okay. So conclusions from this talk on civil registration as the anchor for universal health coverage. These two have been twinned institutions, I think, in most historical cases where they work really well. They're unlikely to work effectively and to be sustainable over many decades, in England's case for centuries, unless they work in harness together. You can create these systems, but I think they'll fall apart unless they mutually support each other. These two institutions should be seen as promoting population health and equity, as well as economic growth, conforming to Amartya Sen's definition of development in his book Development as Freedom. And I think if you engage in policies promoting economic growth and development without these institutions, you may well discover you've got very inequitable development on your hands. Careful attention needs to be devoted to the detail if these kind of systems are going to be created. There needs to be balance between local powers, local devolution of powers, economic incentives for local elites to act. I don't think you can drive these systems all from the centre. They need to be devolved to a considerable extent, and the local elites need to be able to buy into them but be monitored. You need accountability in law. The justices of the peace in England, there needs accessible, impartial law is part of these systems, otherwise they fail to work. they just fall apart in acrimony and you know, corruption and so on. So that's also part of such a system. Although these institutions facilitate economic growth, it's also important to realize that once economic growth gets going in a country, once it starts to become really rapid and once it starts to involve urbanization, these institutions come under particular pressure. It's no good just thinking they'll just carry on. You've set them up and you can now forget about them, they'll function. You need to give them really careful attention when economic growth starts to occur rapidly, or they will disintegrate under the pressure that they're put under, particularly if they're accompanied by ideologies that see free markets and individualism as being the main game, and discount collectivist institutions. Identity registration systems, I think, should always be instituted on a voluntary, consensual basis. I think that if a state finds that its citizens aren't buying in, that it's not getting registration, the state needs to ask long, hard questions of itself. Why do our citizens not trust us? Why aren't they registering? The response should not be to force them to register. I think the voluntary principle is extremely important, and it's almost a diagnostic of the level of trust between the state and its citizenry. So I think that actually registration systems you know, have an intriguing democratic kind of litmus test aspect to them if they're brought in this way. Great care is also required with their technical design. So there needs to be real attention to the security of the information they hold and the stewardship of that information to ensure that these systems are empowering citizens, they're not empowering commercial organizations or the surveillance apparatus of the state. That, I think, is also a really, really important thing that needs to be looked at, especially now that paper systems are increasingly considered to be unaffordable and old-fashioned, and big, powerful multinational corporations are increasingly offering their digital services. One needs to look very carefully at who's controlling the information and the access to that information. Okay, thank you very much.
So I would like to introduce the second speaker, Dr. Colin Masters. Colin Masters, as the coordinator of the Mortality and the Burden at WHO in Geneva, has managed WHO's work on summary measures of population health, burden of disease, and global health statistics from 2002 to present. Prior to joining the WHO in 2000, he worked for the Australian Institute of Health and Welfare for 13 years in technical and senior managerial posts. He leads the team which produces regular updates of child and maternal mortality, life expectancy, and estimates of death by cause, age, and sex for the 194 member states of WHO, in collaborating with other UN agencies, the World Bank, and the academic collaborators. His team maintains the WHO mortality database, which collects global summary data from death registration systems in member states. He also oversees annual publication of the WHO flagship publication, World Health Statistics, which is closely linked to WHO Global Health Observatory. So now, floor is yours.
Thank you. And I should say that Annika Schneider in our department was originally scheduled to give this talk, and she's the person in our team who's been most engaged with the current ferment and interest in actually doing something about improving civil registration coverage in developing countries, which I'll tell you more about. And so, to some extent, I'm speaking on her behalf, and she put a lot of work into the preparation of some of the slides for this talk. So I'd just like to acknowledge that she had to go to a meeting in Washington unexpectedly. So I'm standing in for her, although as you said, I've been long involved with the use of death registration data from the public health side. And so the previous talk, I think, actually was a brilliant sort of introduction and overview within which some more detailed focus on universal health coverage and public health will sit very nicely. But the clear message I got out of that talk was that civil registration and universal health coverage really are twin institutions that need to work together. And so I'll certainly be trying to emphasise that. I'm sure many of you have actually talked quite a lot about universal health coverage, but I'll just very briefly summarise what the concept is, quoting from our director's recent paper. It's basically universal health coverage means that all people in the population who need health services, and that's the whole range of health services from health promotion and prevention through to treatment, rehabilitation, palliation, can receive them without undue financial hardship. And clearly, to achieve that objective, there's a whole lot of policy issues around identifying health needs, identifying what the system should deliver in response to those health needs, how to finance that, and how to monitor and evaluate that you're achieving universal coverage. How do you know the system's working? How do you know it's not wasting the taxpayers' money or the contributors' money? So just to focus in on the elements of universal coverage a little more, if you like, there are three key dimensions. One is along the bottom horizontal axis, extending coverage to the entire population. So, one of the key aspects is who is covered by the system, and I guess we've got a few contemporary examples of major countries attempting to extend universal coverage or some form of comprehensive coverage to the entire population. The other horizontal dimension, heading back into the slide, is the coverage of services, what services are and should be included in a universal system. Now, I think it's universally the case that it's not possible to provide all available potential health interventions that exist, or indeed to empower doctors to do whatever they like. Clearly you do not want to be funding ineffective interventions or interventions that cause more problems than they solve. But even with cost-effective interventions, where is the level of cost-effectiveness? So I was in a recent meeting where somebody from Norway was describing a case where there was a new drug which would keep a kid with cystic fibrosis alive for another 10 to 20 years, but it cost $750,000 a year. Is that the sort of money the state should be providing for an individual, a single individual in a universal system? Clearly very difficult decisions need to be made around coverage. And then the vertical dimension is about reducing the out-of-pocket expenditure to the individuals, or capping it, or ensuring there's a safety net, so that if somebody gets seriously ill, with say a major case of cancer, there's not catastrophic health expenditures that impoverish their family and themselves. And WHO, since around 2000, has been analysing and publishing data on out-of-pocket expenditures and the proportion of the population who are impoverished by catastrophic health expenditures. And in many countries, that's a very substantial number of people. Some developed countries, also some developing countries, there are very significant out-of-pocket expenditures. Some countries introduce systems that cap co-payments by patients to a certain level. Others, a basic level of service is completely free. But reducing the costs shared by patients or limiting the catastrophic expenditures is a key component of this as well. So a nice pretty diagram that Annika put together with multicolours, rainbow diagram. Major elements of universal health coverage is identifying and assessing the health needs and outcomes that the population needs. What is it? What things? Where are the priorities? What services are required by the population? That translates in the green segment to planning and delivering those services. How do you ensure that those services are available to the entire population who need them? And Then the third element that I was just talking about, how do you fund this and how do you provide protection against catastrophic expenditures? So what is the funding source? And I guess in relation to what you were talking about earlier, how do you ensure that the contributors and or taxpayers are not impoverished by out-of-control expenditures, at the same time as providing what's considered to be fair and reasonable access to everyone who needs essential services? And so a key component of all of this is monitoring to ensure that you are identifying the needs, that you're delivering the services that are needed, and that the finances and so on are appropriately managed and money's not being wasted or misspent. So clearly, universal health coverage is data-driven and data-dependent, and I guess the Elizabethan example really makes clear that it was from the beginning in one of the earliest systems that has been documented. And so data on the population and on the health outcomes and needs of the population are a necessary and routine element for designing and managing and monitoring this entire system. And vital registration systems, as well as health information systems within the health services themselves, provide an important platform of data for universal health coverage. I think hopefully that is not a debatable issue. So just to run quickly through the components on the assessing health needs and outcomes, a key component which most developed systems of quasi-universal coverage do focus on is identifying the levels of preventable deaths, and that's also a flag for the associated morbidity from national or population level information on causes of death. That feeds in also to assessing what's a typical longer global indicator or objective of these systems is in terms of promoting a healthy life, a long life expectancy and good health. In terms of the planning and delivery, clearly information on the population is crucial for planning and delivery of services, whether it's the sort of parish registration system of Elizabethan times or, in fact, keeping good track of population in terms of who's eligible for this system and what the numbers of people, age, sex, and indeed much more detail on the causes of death and the profile of the different needs for different health sectors, as well as CRVS data, particularly if they can be linked in appropriate ways that preserve privacy to health management information system data and or other sources of data, can provide an important source of longitudinal information on outcomes, which not only feed back into monitoring the performance of the system, but also research in terms of identifying perhaps more efficient interventions or improvements. And of course the access in terms of identification of entitlement and keeping track of who's entitled and not, and also very importantly when people die that they're not continue to be in the system and their relatives are using their identity to get benefits from the system, as seems to occur in some countries. In fact, in the very early days of my involvement in health statistics in Australia, where there was a universal system called Medicare, and somebody did a record linkage studies of the claims against the doctors database and discovered there were quite a few dead doctors making claims for payments for patient services. And so it's not only the patients who have an incentive, sometimes it's the doctors too, or their practices, I should say. And of course, obviously, with financial protection, data on population, health and survival are very important for modelling and forecasting and managing the sort of financial aspects of the system. So I think this is summarising the monitoring that needs to go on for all those components of a universal health system, and that CRVS is one of the crucial data sources for this. I'll give an example for Australia, and I must say Annika, of Dutch origin, is also an Australian, and so she pulled together some fairly contemporary examples of how the CRVS data for Australia is substantially used by the government sector, and not only the health sector, but all sectors of government. And this just gives an example of the multiple sectors, economic, social, education, health, that make substantial use of population and mortality data, particularly, which is fed substantively by the CRVS system. In particular, in Australia, there's a federal system. The 6 states and 2 territories run their own hospital systems. The primary care and the doctor sector is a national scheme, and so there's a lot of argy-bargy around sharing the income tax, which is collected at federal level predominantly, with the states to run their health systems, and a whole process of national health agreements with benchmarks for the system. And those benchmarks range from health outcome benchmarks in terms of, say, halving the mortality gap for Indigenous children under 5, to a range of more process indicators relating to the performance of the various sectors. But many of these benchmarks are guided by information on causes of death and tracking of mortality rates generally and specific for the population. There's been a huge focus, policy focus on reducing the gap for Indigenous Australians, and that's introduced its own very difficult data issues in identifying Indigenous Australians in the death registration data and in surveys and censuses and other data sources. In particular, in almost all the survey census type information systems and administrative systems, Indigenous identification is according to a definition of self-identification, and in some cases community recognition of Indigenous status, whereas death and birth registration data filled out by relatives, the two sort of identifiers aren't consistent, so there's big issues with that. I guess there was something else I was going to say there and I've forgotten what it was. Not to worry, it'll probably come back to me. Similarly, on the financing side and the eligibility for these systems, again, legal identification and registration are an important component of that, and I think I've already mentioned examples of that. So the whole issue around population numbers, survival, and so on is an important input to government planning, not only in the health sector, but across the whole area of the sort of national planning and budgets and so on. So I've already mentioned a little bit in Australia the particular focus on Indigenous health needs and some of the specific issues that raises for birth and death registration. And these are just some examples that I won't dwell on of some of the indicators and targets that are written up in national agreements between state and federal governments around these funding issues. But underlying this is a whole set of work to turn this into implications for health coverage access for Indigenous populations, because these agreements and writing these indicators basically put pressure on the program deliverers to ensure that they're providing the services needed to achieve these targets, and if they don't, there are funding implications. Because the whole issue of using mortality rates to guide levels of funding of health services at local level is a quite tricky one, and again, in my days in the Australian Institute for Health and Welfare, we were collaborating with the Grants Commission, which set the formulae for sharing the national tax dollars, and they wanted to use SMRs, standardised mortality ratios, at regional level to determine budgets. But the big question was, if the standardised mortality rate was higher in one district than another, should they be getting more money because they have more health needs, or less money because they're less efficient at delivering services and should be punished for it? And there was a big debate around how these incentives work, and it's not a straightforward question to design a formulae that draw on these indicators, but clearly you can't have these debates if you don't have the civil registration data to underlie particularly these sort of area-based analyses of need. I'll turn now from the Australian example to a bit of an overview of the global situation for death registration. And this is, I'm not sure, the graph is a little small. I apologise if people up the back can't really read it, but basically this is 1950 through to around 2012 on the horizontal axis. And each vertical bar shows the number of countries reporting death registration data at summary level to us, which goes into our WHO mortality database, which is accessible through the Global Health Observatory. And so you can go to that and online or download data on the numbers of deaths occurring by age, sex and cause in a country that submitted data. The dotted lines here represent changes in the International Classification of Disease system. So this is version 8, version 9, version 10. These changes all introduce particular problems for looking at time series, but what's of more interest here is the vertical bars. The light shade are high income countries, Western Europe, Australia, North America, etc., Japan. The grey part are upper middle income countries, the dark grey part lower middle income countries, and the black part low income countries. So one of the messages here is there has been a substantial increase in the availability of death registration data with time. So of course it drops off in the last few years because people don't get their data, take a couple of years to get their data together or longer to send to us. But we're talking around 100 countries. WHO has 194 member states, so approximately half the countries are submitting death registration data to us. Now, if you want to talk about the quality, I guess I'll talk about that in a minute. Not all of it is high quality, but you can see there's been an increase in the number of upper middle income countries providing data to WHO. Some increase in lower middle income, barely any low income countries are providing data to WHO. So the big challenge is to address that gap. The countries with the highest mortality rates and the most health problems are those with the least amount of civil registration data to guide national or international policy and priority setting. You already showed this graph, so I won't dwell on it. This is the picture with birth registration in 2013 from the UNICEF report, and we've already had a look at that. Here is a similar picture for death registration coverage. Now, there are a few caveats on that. China, shown as having very low coverage, actually has two sample systems, the DSP system and the vital registration system, both of which register deaths and record cause of death for a sample of communities in China, which is intended to be nationally representative. And I hear that they're now actually making serious attempts to expand and merge those systems with the aim of achieving universal death registration coverage in the foreseeable future. So China actually does generate nationally usable information on causes of death. The quality issues remain, and to some extent, some of the death registration data is questionable quality, but at least they have something. And similarly in India, there's a civil registration system which really only operates in urban hospitals and doesn't generate a sort of representative set of deaths either for the urban areas or for the country. And there's also a sample system, sample cause of death survey, and in recent years there's been efforts to do a nested sample of that and do verbal autopsy by going back to the households and asking about cause of death. Unfortunately, the latest data available from that research project remains 2001 to 2003, although I'm told that several more years of data will be available within the next 6 months, and there, I hope, are plans to scale that up. So India may be on the track to improving its information on causes of death as well. But you can see the huge gap in Africa. There are hospital or regional, provincial death registration occurring in some African countries, in some places, but in terms of generating usable statistics at national level, it's really only South Africa and the Seychelles and Mauritius are the three countries that we get data from that has some usability. South Africa has actually achieved close to 100% coverage with their death registration. In 1994, when the sort of apartheid era ended, the coverage of death registration was around 40%. It's now over 90%. And there's medical cause included in the data except for injuries, where there's the fact that it's an injury is recorded, and that's about it for most cases. Unfortunately, the South African data is hugely contaminated by miscoded HIV. So although sort of HIV deaths in South Africa are, do you remember, Dan, around 200,000 a year or somewhat lower now? The number recorded in the death registration system as HIV is somewhere in the tens of thousands, and the rest are miscoded as TB or infection or various things. So although the South Africans have achieved a very good coverage, the quality of the data remains, on causes of death, remains very poor. So this slide now looks at the quality of cause of death statistics, and we've done some analyses. There's a paper in the WHO Bulletin in 2005 that was the first version of this analysis that looked at the quality of death registration data in terms of a number of dimensions. I mean, the coverage, there's a number of countries where the coverage is less than 100%. So when you get to around 75–80% of deaths covered, you maybe have something that gives some indication of what's going on. But there are still biases in that data, so improving coverage is important. Coverage can also vary by age, so you have some countries where adult deaths are registered pretty well, but child deaths not necessarily, or particularly neonatal deaths. But the other aspects of coverage is the proportion of deaths that are coded to underlying cause of death codes that are valid. And so there are a number of codes in the National Classification of Disease, like heart failure or respiratory failure, that aren't valid underlying causes, because basically to die, your heart and breathing stop. And so that's essentially the end point of the process and not a valid cause of death. And then there's an entire chapter of signs and symptoms. So high temperature, stomach ache are not valid underlying causes of death. And so that's another aspect. The availability of the data itself, and we included a recency factor in our analysis of quality. If it's not been reported, if the latest data we've got from a country is 2005, it's not all that useful for current policy purposes. So this includes a number of these dimensions. If you're interested to look more closely, we did an update of these indicators of quality in the 2012 World Health Statistics Table 10, I think, which is accessible on the WHO website. And you'll notice, for example, Sweden is medium. Wait a minute. Yeah, there's quite a few European countries of medium quality. That's largely because there are something like 10% of deaths coded to ill-defined causes or heart failure. And in fact, the Swedes complained to us that this was unreasonable. They had the longest life, one of the longest life expectancies in the world. And of course, in old people, it's very hard to know what they really died from. So it was unfair to complain that so many deaths were down to these ill-defined codes. But in fact, Finland, Australia, UK all have life expectancies pretty similar and the same issues, and managed to have less than 2% of deaths going to these non-informative codes. So that's the situation with death registration, and I guess I've been involved or aware of the sort of global death statistics since the mid-90s, and in my time at WHO, up until quite recently, there was very few extra countries joined the club of having usable death registration data. I think South Africa, I've already mentioned, is one example. Iran, the two people from Iran came to a burden of disease training workshop we held in 2000, I think it was, either 1999 or 2000, and went back to Iran and created a death registration system out of existing systems that didn't really work very well, which is now extended to all parts of the country except Tehran. And I think there's some activity to try to introduce it in Tehran. And I guess the third example is Turkey, that I can think of off the top of my head, where during the 2000s, Turkey made a big effort to expand its death registration from urban hospitals to the entire country. It's now achieved about 90% coverage of deaths in terms of having a registration, 80% coverage of cause of death, although the quality of that cause of death data is not yet great. But now, for the first time in the last couple of years, there's considerable interest from middle and low-income countries at the national level, health ministers, prime ministers, etc., and actually trying to address this situation and implement or expand systems, make them work. So this slide just summarizes some of the sort of global activity that's been going on. I guess around 2007, the Lancet series you referred to and the Health Metrics Network tried to raise consciousness about the so-called scandal of invisibility. Deaths in the countries with the worst health problems were not being counted or followed, and the data for health priority setting was most poor. As I said, in the last couple of years, there's been a lot of activity, and the Canadian Prime Minister in particular has made an effort to promise significant funding from Canada to seed national activities to develop plans for implementation of CRVS, and a number of countries have already produced such plans and moved to the next stage of piloting scale-up of potential systems. And we and other UN agencies of the World Bank and UNICEF particularly have been also involved in a lot of these activities of providing technical advice to countries around how do you actually start now to practically do stuff. I guess the early 2000s was characterized by rhetoric and consciousness raising, and now it's moved to a stage where people are saying, how do we actually do this? What do we actually do? As I mentioned, down here are listed some of the regional activities. Several of the regions of the developing regions, WHO, the UN Statistical Agency, economic development partners, so the African Bank and so on, have sponsored activities to try to assess the state of death registration data in the countries of the region and to stimulate activity in the country governments to assess and develop an implementation plan to see what could be done practically in their country to start moving towards civil registration. And so there's a meeting, I think the 500 African statisticians and registrars are meeting in January, I think it's actually 2015. And so civil registration is on the agenda for these cross-national platforms and development agencies and national governments in a way that it hasn't been. The conversations like this haven't been occurring until recently. And so again, this perhaps more from our perspective in terms of what's happening in the various regions. I won't go through that in detail. You can clearly look at that in more detail in either the slide presentation or on our website. On the WHO website, there is a page for this activity which gives you links and lists, actually has some of the reports that summarize this sort of work in much more detail. So we've got a couple of slides here showing some of the material that is available through WHO and the other UN agencies. We particularly have focused on the cause of death information because that's where WHO interest in this information both for its own purposes and you know, informing the world but also to providing advice to countries on how to improve their systems for their own use, not just for our benefit. So my team has been heavily involved in preparing and making available basically Excel-based spreadsheet tools for assessing the quality of cause of death systems, so people can dump in tabulations out of their system and get diagnostics. Simple things like proportion of ill-defined codes that are occurring, where are they occurring, is it some particular codes, is it some particular age groups, but also even things like the pattern of causes of death. So you might solve all the so-called garbage code problems, and you've got a system where every cause of death is a valid cause of death. It doesn't necessarily mean the data's good. As an example of that, I was in Azerbaijan a couple of years ago and had a big argument with them because they have a death registration system with causes of death, and 3/4 of neonatal deaths were put down as non-communicable diseases, not cancer. Well, you know, that's just implausible and hasn't been seen anywhere else in the world. And the head of their death coding unit in the Ministry of Health just said, every one of these codes is valid. How dare you impugn the quality of our data? And yeah, so validity of codes and the plausibility of the actual information are two different things, and countries don't necessarily get that right. And even when you do get it roughly right, you then still have quality issues, issues around the way that people locally interpret the ICD system. So that's an area we've barely touched. Is even in the high-income countries, some of the causes of death are not well coded, and I guess of huge policy interest now in developed countries is Alzheimer's and dementia deaths, and the way that they're coded has been a big increase in Alzheimer's death rates. I suspect it's predominantly a change in people's coding behaviour. Where somebody died from heart disease, now they're writing down Alzheimer's, whereas before they wrote down heart disease if the person has dementia. So it's a change in practice, and so we're not really understanding a lot of that. And these are some of the challenges that national policymakers would have also in using these data for monitoring, planning universal health coverage. The World Bank and WHO produced a report, I think it was last year now, which tried to lay out some sort of targets for improving components of the system. And so looking at birth registration, looking at maternal and newborn deaths, child deaths, hospital deaths, and community out-of-hospital deaths. And so we are particularly, we've had a number of expert consultations recently looking at what exactly do you say to a country like Ethiopia who wants to expand its death registration but has barely any doctors outside the metropolitan hospitals. You can't really expect them to implement a medically filled out cause of death certificate. What's the alternative? There's verbal autopsy methods, but they are expensive and require training. And do you ask the local death coder to interview the family around the cause of death and conduct a survey that might have 70 questions, or don't you? And so there's a lot of practical issues around how do you help a country that has very low capacity in terms of its health system to get towards cause of death. Obviously, the first step is to actually register deaths with age and sex, and that's a huge information base in itself. And so we're seeing that getting population-level registration of deaths with age and cause and a few other characteristics is a huge, important first step. Getting hospitals to record and code cause of death for people who die in the hospital is also a hugely important building block to this system, because you then get a health system that has some understanding and experience and trained people who are filling out a form of the death certificate to identify underlying cause of death for hospital deaths and coding it. And that provides a nucleus for expansion and a set of expertise for guiding an expansion into the community when the country gets to the level of capacity. We're also looking at a short coding list. The ICD with 4 or 5 digit codes is very complex and requires a lot of training, a lot of resources, expensive to implement. But for public health purposes, a list of 100 causes will probably capture 80–90% of deaths in the country adequately and be very useful for informing public policy. And we had somebody from South Africa where the Western Cape has introduced exactly that type of short list. They found after a couple of years that for their own internal purposes they wanted to expand that to full ICD, so they had the detail they needed for their own purposes. And I think if these systems can be implemented in a low-cost shortcut way, they will inevitably be expanded because they'll be found to be very useful for local purposes. Us demanding that they use ICD-10 because that'll be really handy for us is not going to cut it. So I guess just a few examples of country reports on their documenting their experience in implementing civil registration. So these are the links for all of these are available for you to follow up if you want to look at them. So I think I've come to the end of the presentation. So I hope I've complemented your very strong message that civil registration and universal health coverage are twin systems that need to go hand in hand, and that data is hugely necessary for implementing or moving towards any form of universal health coverage for populations. And I guess in the last part of the talk, I tried to give an overview of the gathering momentum where civil registration is now on the international policy agenda, on the policy agenda for intergovernmental meetings in most regions. And I think as a growing awareness that civil registration is a hugely important information component that's needed by the national states to address the sort of health gaps and health needs of their populations and to move towards improved coverage of services. Thank you.
Thank you very much. Actually, more information can be found at the WHO's internet site, specifically the technical program site, and the presentations are recorded on the Global Health Histories seminar site at WHO, as well as available on YouTube. So now I would like to give the floor to my co-chair, Sanjoy, who will chair the session of Q&A.
Thank you, Jing, and thank you to the speakers for 2 wonderful talks, which I think blend quite well. Just a reminder, if you have questions, please speak into the microphone. Please identify yourself. As Jing said, these events are recorded, posted on the WHO site and the WHO collaborating site, and we want people to be able to contact each other should they be interested in the comments or anything the speakers have said in the talk or say in their replies. So we have less time than usual for questions and answers. I have a question, but I'll hold back and first let people in the room ask questions. Madam.
Hi, Maria Barrigues from the Reproductive Health and Research Department. I was wondering specifically about the CRVS targets. Are they being incorporated at all, or is there any link with the new Sustainable Development Goals? That's my question.
Yes, I mean, there's the detailed goals that are already being proposed for maternal and child mortality are all about ending preventable deaths by 2030. And clearly, if you're going to monitor that at a country level, you need to be able to measure and monitor maternal and child mortality rates. And vital registration is the sort of gold standard way of measuring. I mean, there are still issues with particularly maternal mortality, identifying it correctly within a death registration system. we are relying on survey data, self-report, for both of these for most of the developing countries of Africa and considerable parts of Asia. And while for child mortality that's possibly adequate, you do have the issue that these surveys occur infrequently. For maternal mortality, they're typically only there are lots of countries with only one survey or two surveys, and it's very hard to assess trends, let alone monitor progress towards a target using data like that. So you might have noticed in the World Bank WHO targets that maternal and child health systems were singled out for a particular set of targets, because it is possible to implement surveillance systems for maternal deaths, particularly in countries where most of the deaths do occur in facilities, ahead of full civil registration, and that provides another point of entry to scaling up towards broader death registration.
Thanks very much. I have two questions, one for Simon. Oh, sorry, my name is Aman Siam. I'm with the Health Workforce Department. I have two questions to ask, one for Simon, one for Colin. Your graphs, when you showed the different sort of almost survivor rates, is quite striking to show the difference between the three cities, Liverpool, the metropolis, and I think it was Surrey. May I ask, is it easy from the historical demography side of things to show some level of health outcomes as the progression of the laws have happened? For instance, the move from the poor law to the next one that happened around 1601 and so forth. Because I think in our line of work, what we always find difficult to put forward is the case of progression of information and data and registration, and how it really has, it have like a tautology effect. Immediately you see how more is understood with data towards better health outcomes. And the second question is for Colin. It was more or less related to the targets. I think I also struggled when I saw those targets 2020, 2025, 2030. Because as you know, the difficulties we have is that targets equal what sort of inputs or priorities or, process progression. And for them to be dumped at a kind of a global level, it takes us away from, as you know, the inequitable situation at the national level. So will those come with some sort of guidance or some sort of instructions or whatever? Thank you.
Okay. Yeah. Thanks for your question. Well, over the long term of the early modern centuries, 17th, 18th, 19th, it's really quite difficult to show precise relationships. I mean, I cited that study about the absence after the 1620s of a relationship between food prices and mortality, which is compelling when you put it into a comparative perspective, that it seems, that something very different is happening in Britain, and it's quite hard to identify any other institution that could be producing that effect. From the point of view of once we get into the 19th century, it was the actual aim of William Farr and people analyzing the data to try to cause responsible governmental institutions to do something about the high levels of mortality he was finding. And at that point in time, because of the ideology of laissez-faire, central government in Britain did not see it as part of its role to do anything about this. But William Farr quite correctly realized that what he needed to try to shame into action was the elected local governments of Britain's cities. So that's why he was particularly focusing on trying to show, in fact, in the 1870s, he created what may be one of the first ever league tables. He started to rank Britain's big cities according to their death rates and their infant mortality rates. And a key term for Farr in his publications was the word preventable. He almost coined this. He kept hammering on about the preventable mortality that he was identifying, and he was demonstrating it was preventable because he could show cities which weren't that much different, 20 miles apart, 40 miles apart, which would have very different death rates. And he would say, shame on the city that's not building water supplies, that's not seweraging itself, and so on. And this is preventable mortality. So once we get into the 19th century, it's still not by no means straightforward because the whole thing is refracted through politics very heavily. That the Registrar General is using this death data to try and create a public discourse and a propaganda and a sensitivity to the problems. But you know, because central government is not acting directly, it's he's having to try to act through elected local government. And elected local government's a whole problem in itself because most of the people doing the electing were small property holders. Was referred to as the shopocracy, and as we all know, trying to get small owners of capital to do anything collectively is very, very difficult because they're very worried about hanging on to their small bits of property and capital, and they don't want anybody increasing taxation on them in any way. So that was a problem, which was eventually cracked, but it was a problem.
There is another WHO meeting right now, so I'm afraid we'll have to conclude the meeting today. I encourage anyone who has more questions to speak to the presenters outside this room. Join us for coffee outside. Alternatively, feel free to email them and continue correspondence with them. Thank you so much.